Hello and welcome to Wellness Wednesday. My name is Sally Duplantier. I am the founder of Zing and the host of Wellness Wednesdays. And I started Wellness Wednesdays at the beginning of the pandemic. We are now in our 5th season with over 14,000 registered participants from 57 countries. I have a mission to help older adults live their best life longer. And today's topic on movement disorders is so appropriate to healthy aging. So I am delighted to welcome Dr. Rachel Dolhun. Welcome, Dr. Dolhun.
Took me a second to unmute. Thank you so much for being here. I'm so happy to be here. And I'll say on Valentine's Day of all days where we talk mostly about the heart, I'm really glad we're focusing on the brain because without the brain, we don't have the heart. So more to come.
Right. I agree. And I wasn't quite sure what to say about Valentine's, but I hope people are noticing my outfit because I'm rocking the pink and the red today. All right. So these programs are free to anybody who wants to attend, but as most of you know, they're not exactly free. There's a cost associated with them. So I rely on the support of the community to help keep Wellness Wednesdays going. So I am very grateful for the growing list of people who help sponsor Wellness Wednesdays. And in return, by being a supporter, you get access to all the different Wellness Wednesdays that we've hosted. There's nearly 100. You can enjoy them at your leisure. You can share them with a friend. So I hope you consider becoming a supporter, because in addition to that, you are doing good in the world. By covering my expenses, I in turn make a personal matching donation. 100% of Wellness Wednesday contributions go to Project Open Hand. So this is a nonprofit here in the Bay Area that is serving healthy meals to sick and vulnerable older adults who otherwise wouldn't get access to healthy food. So thank you. And thank you to our growing list of promoting partners. I've had to make the logo smaller because there are so many new partners that are spreading the word. So now I'm delighted to welcome Dr. Rachel Dolhun. Dr. Dolhun, I realize that I have a creative spelling for your first name. Sorry about that. I just noticed that. Dr. Dolhun and I are part of the American College of Lifestyle Medicine, so that's how we first met. But she is also the lead medical communications director for the Michael J. Fox Foundation for Parkinson's Research. Excellent organization, and they were also instrumental in promoting this. So Dr. Dolhun is very unique. She's a double board certified neurologist, and she's also certified in lifestyle medicine. And she did her fellowship training in movement disorders. She is involved at the Michael J. Fox Foundation in educating and engaging the next generation of Parkinson's physicians. So I am going to stop my share. Dr. Dolhun will present, and then we'll have about 10 minutes at the end for Q&A. So you can type your questions into the Q&A as we go. Welcome, Dr. Dolhun.
Great. Thank you so much for having me. I will share my screen. Here. Okay, all looks good on your end. You can see the slide. Okay, great. Okay, so thank you so much, Sally, for that generous introduction and for the invitation. As I said, I'm really, really glad to be here on Valentine's Day of all days, but it's such an important topic and so near and dear to my heart and to my community. So as Sally said, I'm a movement disorders neurologist, which means I'm a Parkinson's doctor, but I'm also a lifestyle medicine doctor, which means that I'm really focused on how we can use our lifestyle, our everyday activities, from exercise to what we eat to how we connect with others, as some of the main treatment tools for managing life with disease, or in some cases, even preventing or reversing disease. And we'll get into some of that on, for brain health and also for living with movement disorders and things like that. So as you see, we're here to talk about movement disorders, what to know about them, what you can do, whether you live with a movement disorder, know somebody who does, worry about getting one, just worry about your brain health in general. So I hope that you'll see, you'll get a lot of valuable information and you'll get a lot of practical tips along the way. I put these pictures of the water here because I think it's an interesting way to think about movement and movement disorders. So our movement, our walking, how we, grab something and have a coordinated motion, we don't really think about it, right? It's just natural. We've been walking since we were how many months old? It just comes automatically now. So that's kind of the picture on the left. We're on the ocean. We don't even feel the water because it's so smooth and we don't have to worry about it. Then the storm hits. And that's really when we notice something's wrong. It's hard to keep our balance. Things aren't as coordinated or as smooth as they used to be. And that's really when we start to notice there's a problem. And that's kind of how movement disorders come along. You don't notice, of course, until something's wrong. And then there are many ways to adapt and flex to live with movement disorders. But I think that's just an interesting analogy to think about movement disorders themselves. So why should we care about movement disorders? Age, as Sally said, one of her biggest missions is to help people age healthfully, and age is one of the biggest risk factors for movement disorders, including Parkinson's. So we're all getting older. There's nothing we can do about that, but there is a lot that we can do about how we get older and how well we live as we get older. More and more people will be diagnosed with movement disorders, especially Parkinson's disease, in the coming years. A lot of that is because we're all aging and we have an aging population. So a lot of it comes down to the fact that we're getting older. That's a big risk factor for movement disorders. But there are other things that play a role too that we'll talk about. And then probably the most important and why you're here is because there may be a lot of things that you can do in your lifestyle and otherwise to potentially prevent or at the very least delay the onset of brain disease like Parkinson's if it is going to come along one day. So we've talked a lot about movement disorders. Let's describe what they actually are. In the simplest terms, a movement disorder is a brain condition that either causes, again, very simply, either too much or too little movement. So first, why do we call it a brain condition, or why do we describe it as a brain condition? Because it starts in the brain. There's circuitry, there's communication that's not going right in the brain. And that's what's leading to these movement changes. That's different from, say, we get weak or we have arthritis, stiffness in our joints that's impacting how we move. So it starts in the brain. And as I said, it causes too much or too little movement. Now, really broadly, those could be things like too much movement, could be things like tics or Tourette syndrome, extra movement that you wouldn't otherwise notice. You've probably noticed Michael J. Fox having these extra dyskinesia, we call it. We'll get into that a little bit with Parkinson's, but that's an extra movement. There are some other ones that we'll talk about too, but essentially this is just extra movement on top of the normal everyday movement that we have. On the flip side, there's conditions that cause too little movement. Parkinson's is a big one of these. So this would be slower or smaller movements, more difficult movements and things like that. So again, really a general definition, really broad definition here of what a movement disorder is. Now, to give a little bit more information on this, we can talk about the different types of movement disorders. So in those two categories, in the too much and too little, there are many different types of movement disorders. The top three you see listed on the left side of the screen there. So essential tremor, Parkinson's disease, and dystonia. Now, tremor, that's not what I mentioned as too much movement, but that's too much movement. That's extra movement, shaking that you wouldn't otherwise have. Essential tremor, #1 movement disorder, causes tremor among other symptoms. Parkinson's, second most common, causes essentially too little movement, but along life with the disease, you can have some of that extra too much movement. Tremor's one of them. You can also have the dyskinesia, the extra movement that can go along with it as well. Dystonia is another too much movement. So this is a little bit hard to describe for people who live with it or for people who aren't as familiar with it. But essentially what dystonia is an abnormal muscle cramping or a spasm. It can feel real painful, can happen anywhere in the body. And what it does is pull a body part into an abnormal position because of that cramping and that spasm. So this could be things like your head kind of turning to the side involuntarily, or pulling back a little bit involuntarily because those muscles in the back of your neck are cramping or spasming. For some people, it's their toes curling under when their calf cramps, or the foot turning inward. So you can see it's a muscle spasm. It's causing an abnormal movement, an abnormal position. The interesting thing about dystonia is that, as you see here, the third most common movement disorder, so it can be a movement disorder and a condition on its own. It can also be a symptom as part of another movement disorder, including Parkinson's. So some people with Parkinson's will actually have dystonia, or this abnormal muscle cramping, as part of their Parkinson's disease. Again, you see too, kind of tricky with tremor. We've got a condition that's just tremor, essential tremor, but tremor can be part of Parkinson's. So there's a lot of overlap, and it can be challenging and tricky to separate these sometimes. So as I said, top three on the left side, we're going to go into much more detail on essential tremor and Parkinson's disease, but I really wanted to give you just a picture here of all the different types of movement disorders. This certainly isn't all of them, but all the different ways that movement can be affected. Outside of essential tremor and Parkinson's disease, that can include tremors. There are other kinds of tremors that either come with other diseases or are from certain medications and things like that. There's a group of conditions called Parkinsonism, to confuse the issue even further. This is a broad category of conditions that have symptoms of Parkinson's. So like slowness, stiffness, difficulty with walking, tremors, but they're not Parkinson's disease. They're related conditions that can look like Parkinson's disease, but progress and change at different rates and have different symptoms that are associated with them. Always lots of questions too about restless leg syndrome. This is another too much kind of movement syndrome because it causes a real uncomfortable sensation in the leg. Sometimes people say it's like a creepy crawly sensation or a tingling sensation, or just this desire to move. And it actually causes people to have to get up and move, sometimes pace the floor or just move around, oftentimes at night. Movement relieves the symptoms, but it obviously interferes with your sleep if you're having to get up and walk and pace and move around because of this uncomfortable sensation at night. So the other ones listed here, I'm not going to go into in much more detail, but again, just to give you a broad sense of the different types of ways that movement can be impacted. And now we're going to go into much more detail on both essential tremor and Parkinson's disease. So first up, we're going to talk about essential tremor. As I said, this is the most common movement disorder. And I like to start with talking about some famous people who have the condition, because a lot of times it really helps to put that face with the name of the disease. You can kind of see an illustration of how this impacts somebody or how it plays a role in their life. So probably one of the most famous is Katharine Hepburn, an actress. We're going to watch a video of her in just a second where you're going to see how essential tremor can come out. But the other one, which I actually wasn't as familiar with, is Charles Schulz, the Peanuts cartoonist. So many of us know Charlie Brown, but interestingly, you can see here, now that you know that he has essential tremor, shaking of the hands, you can see the shakiness in Charlie Brown there, you know, in the movement of his hands moving, even just in the little glove there. So you can see how this can really play a role and impact somebody's life, their career, their socialization, all those kinds of things. So let's talk a little bit more detail about what essential tremor is, how many people it impacts, why it happens, all those kinds of things. So I said it's the most common. It impacts at least 10 million people around the world. Men slightly more than women, about the same prevalence of men and women, but men just a little bit more. What is it? So essentially, it's a shaking of both hands for most people that happens with activity. So with activity is really the key there, because it can happen in different parts of the body, but the key is that it happens when you're using that part of the body. So if you're using your hands to put on makeup or to type, or to, you know, futz with electrical wiring or woodworking or knitting, anything like that. Pouring a glass of water, holding a cup of coffee, trying to take a sip of soup off of a spoon. That's when this really comes out, is when you're using the body part. So for most people, it's both hands, happens on both sides, both hands. It can also, though, impact your head, your voice. We'll hear that with Katharine Hepburn in a second, and even the upper part of the body. Again, all when you're using it. Now, it's worse, like many medical conditions. Stress makes this worse. Stress underlies so much of our medical conditions and how we experience them, right? This is no exception. Interestingly, essential tremor does get better with alcohol. So many people will notice that when they have a glass of wine or they have their nightcap, that their tremor decreases a little bit. And some people will kind of even use that as a little bit of a treatment tool to dampen down their tremor. This disease does gradually get worse with time. So whereas you might start with a little bit of a more mild tremor that's just not as noticeable or not as bothersome, it may get increasingly worse over time to the point where it is really bothersome, gets more severe, gets bigger in amplitude. And interestingly, as we'll talk about with Parkinson's as well, we've started to realize over the past several decades that it's not just tremor, that this condition can also cause other symptoms outside of the tremor, the movement changes. So it can impact your walking, your balance. It can also impact thinking and memory, and it can impact other symptoms as well. But again, we really focused on the tremor, we focused on the movement. We weren't as aware of these other symptoms that could go along with it. And now we're starting to recognize that much more. It's different, like many of these conditions, it's different in different people. So people will have tremor in different places. It'll affect them in different ways. It'll progress to different extents and at different paces. As we started out the discussion with, it can be really impactful on somebody's life. So we long ago called this benign essential tremor, but got rid of the word benign because it's anything but benign when it's really affecting the things you do day to day. You know, like I said, if you're putting on your makeup and you're having trouble keeping a steady hand, or you're cooking or baking, whatever it is, it can really get in the way of life. It can also be really isolating. You know, social connection is so important for us, being with other people. And for a lot of people, this is understandably embarrassing, or they feel like they're judged, or like people are making up stories about what's wrong with them. And that keeps them from going out in public or from doing as much with other people as they might otherwise. The average age for this, it's a little bit tricky. Some studies have shown that there's a peak both in the 20s and the 60s when you're diagnosed. So maybe, you know, people will kind of be more likely to be diagnosed in their 20s and then more likely in the 60s. Other studies are showing that maybe around the 40s is when it typically comes on. But regardless of when it comes on, it's more likely to happen in older age. So as we talked about at the top of the hour, aging is the biggest risk factor. This is no exception. And so it can happen at any point in life, but it's going to be more likely with age. So why does this happen? Now, inside, the reason that this is happening is because cells in the part of the brain, the cerebellum, that are responsible for smooth, coordinated movement, for walking, they degenerate, they get damaged, they die for one reason or another. And we haven't figured out exactly why that is. Now, for a lot of people, genetics, or those inherited bits of information that we get from our parents, that they get from their parents, that are passed on from generation to generation, plays a big role. So we see in about half of people that there is a family history. For some people, they're able to say, yes, my parent or my grandparent was diagnosed with essential tremor. Other people will just say, you know, we just had shaking in our family. I just noticed that my uncle's hands shook all the time and he never got a diagnosis, or I don't know what it was, or we thought it was Parkinson's, whatever it is. But there often, as I said, is a family history of this condition or of shaking. In other cases, and also combined with the genetics, again, age is one of the components, but then environmental factors. This is another one. We haven't figured all of them out, but there is data to show that things like pesticides, heavy metals, lead, those could all potentially contribute to bringing these conditions on. In most people, as we'll see with Parkinson's, it's probably a complex combination of all of these different factors that we can't quite pinpoint in any one particular individual. And the last thing to say is that there's no test for this. So there are tests that can help us if we suspect that this is what we're seeing. But it's not as simple as a blood test where we can check your cholesterol and say, yes, your cholesterol is high, or no, it's not. Or we can measure your blood pressure and say, yes, it's high, or no, it's not. We're really using our clinical experience. So we're looking at you, we're watching you move, we're looking for your tremor, watching you walk, putting all of these things together in addition to, of course, what you tell us to help make the diagnosis of this disease. So it's what we call a clinical diagnosis, meaning that your doctor talks to you, examines you, and from there, for the most part, we can often make this diagnosis if this is what we suspect. But in certain cases, and we'll talk about this in a little bit with Parkinson's as well, in some cases, there are other tests that can help support what we think is the diagnosis. And now this is really the last thing. I said that was the last thing, but the last thing is that it's not yet curable. So I said it does get worse over time, and we can't yet stop that progression of the disease. We can't yet reverse it, but we can treat it, and we can treat it in different ways. Medication is a big one. There are a variety of medications that can help decrease the tremor. Surgery for some people can be an option. There's something called deep brain stimulation or focused ultrasound. So there are surgical options for some people if it gets that significant, or if medication, it doesn't work enough to help decrease the tremor. And then there are a lot of devices out there to kind of just help people navigate life a little bit more easily with the tremor. So those could be things like weighted bands that if you add a little bit of a weight to the wrist, they can decrease the tremor somewhat, or weighted utensils to make it a little bit heavier and again, dampen down the tremor. So lots of things that are out there that a lot of people try to just, as I said, help them navigate life more easily despite having this condition. So I said we were going to watch a video next, and you're going to hear, so before it's going to play automatically. So before I move to the next slide, I just want to introduce it quickly. So this is just a video I pulled of Katharine Hepburn speaking. As I said, she famously had essential tremor. And interestingly, you can really hear it in her voice. So really pay attention to when she's speaking, and especially when she's holding a word for a little bit longer, you can really hear that tremor come out.
We are people of the same interests. In a few moments, Lawrence Weingarten will be standing by my side. On this table is the Thorberg Award.
So you can hear it there, it's pretty subtle, but because we know that she's got this tremor, and she's obviously very practiced and very polished, and she's done a lot of work to keep this under the best control she can, but you can still hear it come out, a little bit of that like vibration in her voice, especially when she's, as I said, holding a word for a little bit longer. So now we move to Parkinson's disease, and we'll spend a little bit more time on this. Because this is my focus, of course, and because there's a lot of interesting similarities and differences compared to essential tremor. So Parkinson's is the second most common movement disorder. Just like we did with essential tremor, I think it's interesting and helpful to start with the faces of famous people who live with Parkinson's. And you see here, more people, we know many more who live with Parkinson's, interestingly, even though essential tremor is more common. And there's a big diversity, men, women, people of different races, ethnicities. So this disease can strike anybody at any age, of any race, any geographical location. So just quickly, in case you're not familiar with the people on this slide, Michael J. Fox, I think most people know that, my foundation's namesake. Muhammad Ali, a boxer, Janet Reno, Neil Diamond, Brian Grant, a young basketball player, Ozzy Osbourne, a famous musician, Alan Alda, an actor, and then Reverend Jesse James. So again, you see people from kind of all walks of life, all different careers. And Parkinson's, there's many, many faces. We often say it's a unique and boutique disease because it impacts people so differently. We say when you've met one person with Parkinson's, you've met one person with Parkinson's, because it can be so different from person to person. So let's, just like we did with essential tremor, we're going to dive into more details on Parkinson's on this slide and the coming slides. So it affects at least 6 million people around the world. So like slightly less than essential tremor, but still a pretty significant amount. Men impacted more than women, and this ratio is bigger than in essential tremor. So men about 1.5 times more likely to be impacted with Parkinson's than women. Because of aging, because of other factors, experts estimate that the numbers of people living with Parkinson's are expected to at least double by 2040. So that means 12 to 13 million people. Those are our estimates, maybe even more than that, will be living with Parkinson's by the year 2040, less than 20 years from now. And it's not, of course, just the people who live with Parkinson's, but it's also their families and their friends and their communities. So many people already and increasingly impacted by Parkinson's disease. Because of the way that these numbers are expected to double, you can see on the top of the screen here, we call it the fastest growing neurological condition. So what is Parkinson's? What are the core symptoms of Parkinson's? The biggest one isn't tremor, although that happens in most people. It's slowness. So to be diagnosed with Parkinson's, you have to have slowness. And that can look different. It can be a general slowing, like you just can't keep up with your spouse, so you can't walk as long as you used to be able to. You're slower with specific activities, like buttoning is hard, or it's hard to type or text or move the mouse. The slowness can come out in different ways. Like I said, either a generalized slowness or with specific activity. For some people, that quote unquote slowness might even be the first sign of it might even be one arm not swinging as much when you're walking. So that's one subtle sign and clue that we often as doctors look like when we watch you walk is, how are your arms swinging? Because they naturally swing when we walk, but for a lot of people with Parkinson's, one arm will start to just kind of stay by the side or not swing as much. And then after the slowness, you have to have either shaking or stiffness. You can have both, but you have to have at least one of them. So let's take the shaking first. This is the tremor. It's different than the tremor of essential tremor because it typically happens on one side, at least to start, and it happens at rest, not with activity. So this would be, I notice my pinky or my hand or my arm starts to shake a little bit when I'm resting it in my lap. I'm just watching television or I'm looking at something on the computer. I'm not using my hands. And that's when I notice this odd shaking activity when I'm resting. The stiffness, it can feel like a muscle stiffness or a tightness, especially in that one arm that's not swinging, if that's what's happening. In the shoulder, a lot of times people will notice this, especially younger people. They'll feel a stiffness and they'll get sent to the orthopedist and the chiropractor and the physical therapist, because who would suspect Parkinson's in a young person and they have stiffness? Maybe it's their old rotator cuff injury. But then we start to see other things and we put things together. So it can be, as I said, it can feel like a stiffness or a tightness in the muscle. But really what this is we're looking for this, the doctors are looking for this on your examination. We're moving your arm and we're feeling, does it feel rigid? And does it feel stiff when we try to move it, when we tell you to relax, but it just doesn't, the muscles just don't relax, even though you're relaxing them as best you can. So these are the core motor or movement symptoms of Parkinson's: slowness, stiffness, and shaking. You can also have walking and balance problems, usually pretty subtle early on, may get a little bit worse the longer you live with Parkinson's. These subtle walking and balance changes are things like the arm not swinging, as I mentioned, or taking smaller steps, or shuffling a little bit. The feet don't want to pick up quite as much from the ground. Turning around in multiple steps versus kind of pivoting like we do. Again, don't think about this until we notice there's a change or a problem. So as I said, those are the motor symptoms. Those are what we look for at the time of diagnosis. Those are how we make the diagnosis of Parkinson's. As I mentioned, not everybody has tremor. About 75% of people do. So most people with Parkinson's will have a tremor, but there is a subset of people that do not have tremor. As with essential tremor, these symptoms gradually get worse with time. The important thing about Parkinson's is that it's much more than a movement disorder. So the movement symptoms that I've spent so much time talking about, those are really recognizable. A lot of people associate those with Parkinson's. What fewer people, even those who are newly diagnosed or just starting to live with Parkinson's, recognize and realize is that there are so many other what we call non-motor or non-movement symptoms that can go along with it. These are sometimes what we call the invisible symptoms because you can't see them from the outside. They can impact really any body system from the head to the toes. So it could be vision, it can be smell loss, it can be heart changes, rhythm changes in some people, GI, constipation, bladder changes, even skin changes. So all kinds of symptoms that don't always, but can go along with Parkinson's. And for some of them, interestingly, they can happen decades before the motor symptoms come on. So we see things like maybe smell loss or certain sleep conditions, something like acting out your dreams called REM sleep behavior disorder or constipation. These in some people can come on years or even decades before those motor symptoms happen. And it's not until those motor symptoms happen and we can make the diagnosis of Parkinson's that then we can say, oh yeah, that all goes together. Or people will often say, gosh, I've always had mood changes. I've always been an anxious person. Now I realize that maybe that's part of my Parkinson's. Or yeah, I was acting out my dreams. I accidentally punched my wife and fell out of bed a couple times. Oh, you had REM sleep behavior disorder. You were acting out your dreams. Decades later, you developed Parkinson's. So again, we're starting to put much more together about how these, the non-motor symptoms can go with the motor symptoms. They can happen any point in the journey with Parkinson's from decades before to decades into life with the disease. They don't always happen. They're different in different people. But these are, I think one last thing to say on this, an important clue to potentially understanding more about how Parkinson's comes on. Because if we can understand more about what happens from the point of acting out your dreams or from losing your sense of smell, we can understand how Parkinson's is coming on, why it's coming on from its very earliest moments. And we can potentially then intervene to stop Parkinson's from getting to the point of motor symptoms, to the point where we know it's happening now. And a lot of research is focused on that. So the average age for Parkinson's, most people are aware it happens more in older people. So probably late 50s, early 60s is the most common time to be diagnosed. But as you can see from our group of people who have Parkinson's, it can happen at any age. So Michael J. Fox was only 29 when his symptoms started. Brian Grant, I believe, also in his 20s. Many of the others were older, were around, their 50s, 60s, and beyond. So for most people, it does happen in later life, but it can happen at any point in life. So this is a video here, no sound here, but just to illustrate what the tremor of Parkinson's can look like. So different in different people, but you notice it's happening really when people aren't really using their hands. It can be, it can be different sizes, different amplitudes, different frequency, different speeds. I'll play that just one more time because it kind of came on real quick.
And Dr. Dolhun, while we're watching this, somebody wrote into the chat, is losing taste a symptom of Parkinson's? I think you said that it was.
It's a really great question. So sense of smell is a big one, right? So losing your sense of smell, it's a big one for Parkinson's. It's a big one for aging. It's a big one for a lot of diseases. So smell decreases, our sense of smell decreases as we get older. So some of that is normal. A lot of us have experienced smell loss temporarily for other reasons, right? COVID was a big one. I lost my sense of smell with COVID. So a lot of us had that temporary experience. It can happen because you smoke, because you have allergies, because you have chronic sinus disease. So many different reasons for this. So I don't want to be alarmist and say, smell loss definitely means there's a brain disease happening. But when it's very severe and significant and ongoing, it can be a sign of brain diseases like Parkinson's. And to answer the question directly, our smell is directly linked to our taste. So when we can't smell things, and again, anybody who's lost their sense of smell with COVID or something else, you realize what a strange experience this is, right? Where you know something, you smell something, and you know that it's supposed to smell a certain way, chocolate chip cookies baking or pizza in the oven, and you have an idea of what it's going to taste like because of that smell, and that you can't taste anything. So that's because a lot of our taste comes through our smell. So when we lose our sense of smell, we lose or decrease our sense of taste as well.
Thank you. And some people were typing into the chat, and I said, we'll save the rest of those questions.
Okay, great. Yeah, we'll have time at the end. Okay, so why does Parkinson's happen? The main reason is because cells in the brain that make dopamine, a brain chemical that's responsible for normal movement, as well as for motivation, for mood, for reward, all kinds of things, those brain cells decrease or die. Now, why they do, big mystery we haven't yet solved, but it's likely, as in essential tremor, this complex combination of getting older, number one risk factor, getting older, plus our genetics, the information that we inherit from our parents, and then our environment. So you can see on this slide that the majority of people who live with Parkinson's, it's likely that they have this complex combination. Now, as far as genetics is concerned, we have identified several genes that are linked to an increased risk of Parkinson's, but it's not the one-to-one. Like if you have the gene, you have a 50% chance of getting Parkinson's or things like that. It's much more complicated. And of course, this audience is very educated. You know that your environment impacts your genes. So it's not just having specific genes, it's how you live, your surrounding area that impacts how your genes are expressed. So even having that risk for Parkinson's, again, doesn't guarantee that you'll get it. And maybe even you have a different risk depending on how your environment and your lifestyle and those sorts of things. Building on that, I wanted to talk about environment for a little bit longer, because I think this is a really interesting part where our environment can play a big role in Parkinson's risk, but there's a lot that we can do. And one study even estimated that up to a third of cases with environmental factors that play a role could potentially be prevented. So on this slide, you see a variety of factors in our environment or in our lifestyle that play a role in Parkinson's, either positive or negative. The negative is blue. If you can see the little dotted lines, the negative associations are blue. Negative is actually good in this case. So it's a little bit backwards, but a negative association means there's a decreased risk of Parkinson's. So for regular exercise, for drinking coffee, there's a decreased risk of Parkinson's in people who follow those lifestyles and those activities. On the flip side, a positive risk, a bad risk in people who have traumatic brain injury, who are exposed to pesticides, solvents, heavy metals, air pollution. Dairy consumption has been linked to Parkinson's as well. This is a little conflicting and a little bit inconclusive to this point, but higher amounts of dairy have been linked to increased risk of Parkinson's. Same with psychological state. So chronic stress, back to stress as the underlying factor for a lot of our conditions. Stress has been linked to Parkinson's disease as well. It's important to point out that all of these are just associations. So none of them is proven as cause and effect. We haven't proven that drinking coffee is the reason that some people have lower risk of Parkinson's. This is just us gathering data from large groups of people, populations of people, where we can start to see trends and patterns and associations. And it helps us then investigate even further. Oh, if coffee decreases risk of Parkinson's, what is it about coffee? And actually, based on that, there was a new Parkinson's medication that was developed that works on the same receptors as coffee. Cigarettes, an interesting one to point out. You see that there's a negative association, meaning that people who smoke are less likely to get Parkinson's. We wouldn't recommend anybody take up smoking for this reason. There's a lot of other bad risks with cigarette smoking, but again, an interesting association that we can then take a step further to say, what is it about smoking and about cigarettes that might be playing a role in Parkinson's? So again, the takeaway from this slide is there's a lot in our environment. I think for me, that can feel a little bit deflating sometimes, right? There's so much around that can't necessarily do a lot about, but there really is a lot that we can do a lot about with our lifestyle, with how we live, with how we interact with the environment. So that's really the takeaway from this slide. So as I mentioned, and as with essential tremor, there's no one test for Parkinson's, but because of recent research and a lot of new developments, that's starting to change. So where are we today? I mentioned those motor symptoms of Parkinson's. I mentioned all the things we look for. Today, Parkinson's is diagnosed in a doctor's office after your doctor examines you, watches you walk. A lot of people will say it's very unsatisfying because they tap their fingers and they open and close their hands and they tap their feet and they walk down the hall and they touch their finger to their nose. And then their doctor says they have Parkinson's. And they wonder, how could you possibly know that just from looking at me for 15 minutes? So this is how we diagnose Parkinson's today. We're looking for those motor symptoms. We're listening to what you tell us. We're looking at your exam. We're asking about all those other non-motor symptoms we talked about. And then we're making a diagnosis based on that. So that's why it's really important to, if you're concerned about Parkinson's or you have signs or symptoms of it or things that you worry about, to see a doctor who specializes in Parkinson's and essential tremor and other movement disorders. And that's a doctor called a movement disorder specialist. So that's like me, where I undertook extra training after my neurology training to study and focus just on Parkinson's and other movement disorders. Now, I mentioned there are specific tests that can help. So not in and of themselves, you know, again, it's not like that cholesterol test or that diabetes test where we can do a blood test and say yes or no, you do or don't have it. But it can help when we put it in the context of what we see and what we learn from you, it can help us. The biggest one of those tests is something called a DAT scan. This is, you see that picture on the top there. So this is a specialized brain scan that's looking at the dopamine in the brain, essentially. Where this can be really helpful is if we can't quite tell based on your exam if it's essential tremor or it's Parkinson's, because essential tremor doesn't impact dopamine. Parkinson's does. So when we do a brain test to look at dopamine, we can see it's low or it's decreased in Parkinson's, and it'll be normal in essential tremor. So that's where DAT scan can be really helpful at separating those two. And then I mentioned that there are many more tests that are just coming out now, so early days on these, but newer tests that can help us look for the abnormal changes in proteins and other things that we see in Parkinson's. We can do that through a spinal fluid test, a lumbar puncture. We can also do it through a skin biopsy. And as I mentioned, these are early days, so they're just kind of starting to come out in the clinic, and doctors are really figuring out how they can be most helpful. Like the DAT scan, these will be an additional tool. They won't be anything in and of themselves, but they might be an additional tool where in certain cases where it's not cut and dried or perfectly clear whether it's Parkinson's or something else, these tests can help us by saying yes or no, those abnormal Parkinson's proteins are there or they're not. And that can give us another piece of information. For the current time being, these are really helping our research. So they're helping our research to develop drugs to understand more about Parkinson's, really move forward a lot better and more efficiently. But in the future, these will be a much more standard part of clinical practice, especially when, as the work we're doing now to make them more accessible, like when they become a blood test or when they become a nasal swab or things like that, they'll be much easier than having to go in and have a spinal tap. Nobody really likes to volunteer for that, or even a skin biopsy is, you know, less invasive, but still, you know, if we can just turn these tests into something that could be a blood test or something like that, they'll be much more available and useful in our clinical practice. Again, like essential tremor, we can really treat Parkinson's pretty well, especially the motor symptoms and especially early on, but it's not yet curable. We can't slow that progression that happens over time and how those symptoms change over time. That being said, there are a lot of tools that we use in different combinations in different people, depending on them, their approach to treatment, their lifestyle, their symptoms. We use all these different tools in combination to treat all the different symptoms. So medications are really a mainstay. You've probably heard, if you know anybody with Parkinson's or you've read anything about Parkinson's, you know about the medication called Sinemet or levodopa. This is kind of the basis of our treatment. It's giving back that dopamine that's decreased in the brain that helps with movement. So lots of medications that focus on dopamine or on boosting the dopamine that we have left in the brain or that we give through other medications. So lots that we can really do, especially for the slowness, the stiffness, and the shaking. Not as much, we're getting there, but we're not as good quite yet on the non-motor symptoms, the sleep or the mood or the memory and thinking changes, all those other symptoms that can go along with Parkinson's. We're also not as good at the walking and the balance problems. So that's where things, if I skip ahead to therapy, that's where things like therapy and even lifestyle can really come in and complement our medications. Because if we have balance problems or we have walking problems, physical therapy can really help. We've got trouble moving our fingers, because of slowness that we can't quite get at with medication. Occupational therapy can really help. Mood changes that are impacting our daily life, our quality of life, mental health therapy. All of these things can really complement our medication and really fill in the gaps there. I'll jump back to surgery. This is an option, just like with essential tremor. I mentioned 2 types of surgeries, deep brain stimulation and focused ultrasound. These are surgical procedures that both treat the symptoms. They don't change the progression of the disease. They don't cure the disease. But in some people, these can be good options when medication just isn't quite enough anymore, when medication is working, but it's causing a lot of side effects or changes. So in some people, especially years or a decade into Parkinson's, these can be options for them. And then, of course, lifestyle. This is a huge component of treatment for everybody with Parkinson's. Exercise is actually one of the only tools that we have today that could potentially slow the progression of Parkinson's. So early studies, small studies, but they are showing that we could slow the progression of Parkinson's with exercise. So I always tell people, don't wait for the study, right? Let's get out and exercise today. If there's a chance that that could be beneficial, that could slow disease, why wait? It can also help you feel better, help your mood, help your constipation, help your medication work better. So, there's no reason to not exercise. Diet too can be a really powerful tool for helping manage Parkinson's. Maybe helping with progression, but more importantly, helping with all those symptoms. So there are ways we can adjust diet if we have constipation, if we have swallowing changes, even if we have smell loss and food's not as appealing because we can't taste it and smell it as much. There are a lot of things we can do to adapt the diet and adapt how we eat to make it more palatable and appealing. So you might be sitting there wondering, well, that's all fine and good, but I'm getting older, and how do I know what's getting older and what might be something else? This is something I hear all the time from people who are living with Parkinson's too. I'm 60, now I'm 70. I don't know, I've never been 60 or 70 before. So am I just feeling slower because that's just what happens when you turn 60 or 70? Do I feel more stiff because I've had these bones and joints for 70 years and that's just what happens. So it's really hard to know what's what. I put a couple examples on this slide of things that might be normal aging versus things that might be something else. And this isn't meant to be a be all end all or something that you're, like kind of mentally going through like, oh gosh, do I have that? Do I have that? Do I have that? But it's meant to help you start to think about this. What might be normal as we get older? Things change, our brains change, our bones change. It's expected that we will have some normal changes with age, but it can be really hard, as you know, and as I mentioned, to know what's just normal aging and what could be something else. So a couple examples here. I won't go through every single one of them, but a couple, I think illustrative examples. We all misplace our keys, right? I do that. I'm in my 40s and I misplace my keys or my glasses or my whatever. That's normal. We all do that. We all walk into a room and forget why we walked into the room. It's more about if you forget how to use your key, or what, can you not put that key in a lock, or do you have trouble now with driving or things like that? So it's more about not the just misplacing maybe, but about the process and how to incorporate those keys. Another one, shaking, is a good one. So all of us have a tremor. We all have a what we call a physiological tremor. And you'll see this tremor come out when you're really nervous, somebody frightens you, you've had too much caffeine, sometimes even some medications bring it out a little bit more prominently. We can feel it, sometimes we can see it, and that's normal. What's not normal is the things we talked about with essential tremor and with Parkinson's. So you start to see, gosh, this is really weird. My hand is just shaking out of nowhere when it's just sitting in my lap. Or, every time I'm trying to pour my cup of coffee, it's spilling all over the place because I just can't, my hands are just shaking so badly. Those are going to be things that you want to pay more attention to and might signal that there's something else going on. Another one is, I mentioned that a lot of the non-motor symptoms, so the changes in bowel, sleep, and mood, those can be early signs of Parkinson's in some people. And this can be a really tricky one because we can all experience those things, especially as we get older. Our bowels slow down, we might have more constipation, naturally sleep changes. So we might just tend to wake up earlier in the morning or have more trouble falling asleep. Our mood might change because we lose friends or, life changes in different ways. So some of these are, not normal, but part of aging. It's when they get to be really significant, especially when you have more than one of them and they're really impacting your life. Gosh, I never get sleep anymore. I'm exhausted during the day. My mood has really changed to the point where my behaviors changed and people have pointed out to me that I'm not acting like myself, things like that, where then again, that's a signal that there might be something else going on. So again, these are just examples. I don't want you to, jot them all down and think that, oh gosh, I checked, 3 of the boxes and something must be wrong, but they're just ideas to get you thinking about, how do we as doctors, how do we as people think about separating these things?
And Dr. Dolhun, I'm going to jump in. We can go to that next slide if you want, but then we have so many good questions, and I want to make sure we save the last few minutes for questions here. So
yes, I'm talking too long, so let me speed through. I told you I would talk too long, so I have too much to say. So how can you be sure? A couple things. You can take notes, look at, keep a log so you can notice patterns, look back at old photos or videos to see how your movement might have changed. The biggest one is really talking with other people. So both loved ones, especially those who don't see you as often and might recognize a bigger change versus the ones who see you day to day and might not notice those subtle changes. And then comparing yourself to others. So what do your peers experience and notice? Are they saying like, yep, I always lose my keys too, and that's totally normal. So those things can be really helpful. And then anytime you notice anything that's concerning, of course, see a doctor right away. And then I'll end here, but I just want to stress that it's, as you all know, it's not, there's so much that you can do to keep your brain healthy and to potentially even prevent or delay the onset of disease. So exercise, not just cardio, but do your balance exercises, your flexibility, your strengthening exercises. Eating a whole food, plant-forward diet. There's most data on the Mediterranean and the MIND diet. So both of those really focused on whole food, plant-forward concepts. You don't have to be tied to that, but think about those concepts and incorporate those. Sleeping as well as you can. I mentioned it changes with age. So that's going to happen, but there's a lot that you can do in your daily life. How much you move, how much you exercise, when and what you eat, how much light exposure you get, that can really impact how well you sleep. And then connect with others, be part of your community, manage your stress as best you can, limit your harmful exposures, including alcohol, which is never a popular thing to say. But there's a lot that you can do. You don't have to do all of this, but take a step, at least do one of them. The other pieces will fall into place, and know that there's so much that you can do to keep your brain healthy.
And I'm going to jump into questions if I can. So this is super helpful, Dr. Dolhun. Some of the questions came down to specifics. So there are a lot of questions about exercise and Parkinson's. There was questions about bicycle riding. Do you have, in your experience, a preferred form of exercise that's best for Parkinson's?
Such a common question. And the short answer is no, there's not one best exercise. Oftentimes we'll tell people, do the exercise you enjoy because you'll do it regularly. It's so important to just do exercise. I did just publish a guide on exercise in Parkinson's that we can share the link on. But the critical thing, as I alluded to here, is that it's not just cardio. So you've got to get in your cardio, your aerobic exercise, at least 150 minutes a week. So that's like 2.5 hours spread over the week. The intensity is important, so the higher the better, but anything is good. There are different ways to measure your intensity, whether it's a smartwatch or whether you can talk or sing or that sort of thing. So making sure that you're getting in the amount of cardio, the intensity of cardio, and that you're complementing that with the strength exercises, the weightlifting. It can be body weight, but you're doing weightlifting. You're keeping your bones and your muscles healthy. You're adding the flexibility and the stretching, and then you're adding in the balance, which is so important for all of us as we age.
Yeah, and those are the guidelines of the American Heart Association too. So yeah.
Yeah.
Rima asked, her dad has Parkinson's and he can't sleep because he has lots of energy and movement at night. Is there a way to help him with this?
It's such a challenge in Parkinson's with sleep, and I'm sorry that your dad is having so much trouble. There are many ways that we can manage this. So I mentioned the sleep that we call the sleep hygiene. So thinking about what does his day look like? Really, a lot of times we focus so much on the night, but think about what the day looks like. How much movement is he getting in? Regular exercise, light exposure. When is he eating his last meal? Is it too close to bedtime? And that's interfering with sleep. But then for people with Parkinson's who have symptoms close to bedtime, there can be sometimes medication adjustments that we can do if it's hard to fall asleep because symptoms are happening. If symptoms wake him up in the middle of the night, we can often do medication adjustments that help with that. And then, of course, if it gets to the point, melatonin can be really helpful for a lot of people. Of course, talk with your doctor about if that's an option, but melatonin can be really helpful for sleep in people with and without Parkinson's. And then there are other medications we can try if none of that is successful.
And Dr. Dolhun, one of the participants, Anne, asked if there was a relationship between Parkinson's and viruses. She had read that people who survived the Spanish flu had gone on to develop Parkinson's. Do you know anything about that research?
That's right. There is a link between certain viruses, including the Spanish flu. We're also seeing some with COVID as well. The challenge with this is it's hard to know if it's the virus itself or if that's just the trigger that brings it on, that Parkinson's was kind of there brewing under the surface and that this insult, this acute change brought it on. And we see that with a lot of things, not just viruses or infection, but also people who, have an accident or a trauma, or they're in the hospital, or they get sick for another reason. And then all of a sudden Parkinson's comes out. And we think it's just that association that the body's stressed for one reason or another. And that's what sort of tips it over the edge and brings that Parkinson's that was there under the surface up above.
This is so helpful. I'm just trying to get through as many as possible before the top of our hour. How about ADHD? Is that a risk factor for Parkinson's?
There is a link between ADHD and Parkinson's, but it's hard to know what's what. So they both impact the dopamine system. As we said, dopamine is impacted in Parkinson's. People who have ADHD often take medications that impact the dopamine system. So is it that there's some circuitry and biology that's the same, or is it the medications that we use that are bringing this out? But there is an association between those two conditions.
Yeah, thank you. How about somebody was asking about liftwear products. Are you familiar with those? They're assistive devices for hand tremor. I've not heard of them.
Yeah, that's what I was mentioning with the devices that people will often use for essential tremor or for Parkinson's. And there are many different kinds. Liftwear is one example, but these are sometimes like weighted, heavier and bigger handles on the utensils that make it easier because they dampen down the tremor. Some of the fancier ones even try to kind of compensate for the tremor. So if you're shaking, they'll sort of go the other way. But this is an example of one of the tools that's available to help navigate. I mean, there are all kinds of things you can think about, ways to apply makeup, tools to apply makeup or get dressed or button or put on shoes or, all kinds of things that you can think of. And this is a place where occupational therapy can be really helpful at guiding and directing to the specific tools that would be helpful for you.
Yeah, thank you. This is a question from Connie, and it's a good one. Can essential tremor be reversed if the cause is related to heavy metal exposure on metal hip implants?
That's a good question. My sense would be unlikely. You know, we get this question sometimes with Parkinson's, for example, where people will say, I was a farmer and I was exposed to pesticides for years, or I was a welder and I was exposed to manganese. And, you know, if that caused it, could we reverse it? The challenge is that we're already past where the damage has been done. So when Parkinson's is diagnosed, for example, 70 to 80% of those dopamine cells are gone. So we can't yet reverse that damage and that cell loss. You know, that's why we're working so hard on prevention to even prevent it from getting to that point. But you know, it's good to know the cause, but unfortunately, we're not yet at the point where we can reverse these things.
Yeah. And our last question, because I see we are at time, has to do with autism. Is autism a risk for Parkinson's disease?
Not that I'm aware of, but more and more research, of course, to understand these different brain diseases and how they connect: Alzheimer's, Parkinson's, ALS. We're understanding so much more about the biology and how they overlap and how they differ from each other. So probably more to come as this is studied more in the coming years.
Dr. Dolhun, thank you and your team so much. I will be sending the recording. I will also be sending a host of different resources. So there will be a lot of takeaways from today's presentation. I learned a lot. I hope our audience did too. Thank you so much for joining us.
Thank you so much for having me.
Have a good day and happy Valentine's, everyone.